الشحن بتاعي.
ايوه يا احمد، انا في اجتماع هكلمك كمان ساعه كده. خلي تليفونك مفتوح. طب سلام عليكم.
Good to see you too, Samal. How are you? You well?
Yourself, I could see you, Professor.
Oh, can you hear me now?
Okay.
I'm okay. I'm okay. Can you hear me?
Yes.
Always a pleasure to see you, Sam.
How are you, Dr. Qureshi?
I'm very well, Professor Arman. You well?
Fine.
That's nice. Nice.
Great
to see
pleasure
you.
great pleasure to be here.
Thank you very much.
You
It's always a pleasure to be with my Egyptian brothers.
Yes, I think you have got the Egyptian nationality,
Alhamdulillah.
شكله مش جاي احراج بقى دلوقتي، الناس مستنيه وهو مش لاقيين وعمالين يدوروا عليه مش لاقيين. ربنا يعديه على خير بقى.
You can call him يا ناصر.
الخواجة بتاعك فين امال يا عم ناصر؟
كلمه يا ناصر.
Mohammed, how are you?
I'm fine. How are you?
I'm very well. Everything is okay here. Can't hear you very well. Can't hear you very well. But
How is the weather in your country now, Dr. Qureshi?
good. It's a bit cold. We are at about 19 degrees, 20.
How many degrees?
Yes, it's cool.
Can you say it loudly, please?
It is cool. It is cool.
Oh, you are lucky.
You
Here
must
in
be.
Upper Egypt, it is hot.
I know. It is nearly 45, yes?
Not to that extent, it's around 40.
40 for us is too much.
Sometimes it gets to 45. Sometimes.
Even 40 is too much for us.
here.
question? Yes, please.
I was just wondering whether we have any information about Professor Luton.
Dr. Nasser tried to call him to know what's happening. He's trying to call him. I'm wanting the information from Dr. Nasser.
Okay.
Sorry for that. Sorry for that.
Yes. Part of neurosurgery. You have to accept it.
Yeah.
ولا حاجه ابعت له نسي يا خساره نسي اغنيه الحاجات الصغيره.
نعم.
فكر ولا حاجه.
مش سامع. نعم دكتور اسامه.
ايه؟
بتقول يا دكتور اسامه مش سامع.
بعت له اغنيه نجاة الصغيره نسي يا خساره نسي.
مشكلة النيوروسيرجري it's the only field that has an emergency all through يعني.
That's true.
It's a fine gathering today, actually. It's a fine gathering.
Yes.
A lot.
احتمال معاه عملية عجل.
محتاج مساعد بقى. اخبار الجو عندكم يا دكتور رضوان بيه؟
حر يا دكتور
حر جاف صيفا ممطر. The weather in the Kenya is better than Aswan, you know?
Dr. Qureshi saying it is cold.
Oh, it is 20.
Yeah.
It is cold.
21. It's nice weather.
How come Aswan weather is quite hot and the Kenya is quite cold?
Yes, Kenya is our winter period now.
We should have another home at Kenya, Dr. Qureshi.
Oh, you have one. Welcome back.
Yes.
Only Corona who's messing us up. Otherwise, your home is
That's
here.
right.
Muhammad has been here many times. Muhammad. This time it is Masai Mara is one of
your voice is quite far away, Dr. Muhammad. دكتور محمد الصوت بعيد قوي. دكتور محمد صوت سيادتك بعيد. واضح. دكتور محمد بيه. صوت حضرتك بعيد. يعني قرب حضرتك شوية. لا انكلير. صوتك انكلير خالص يا دكتور محمد بيه. نعم. انكلير يا دكتور محمد. صوت الانكلير.
Microphone is not working very well.
Dr. Fiki, your phone is not clear. Your mic is not clear, Dr. Muhammad. حضرتك في الساحل ولا ايه؟ ها؟ لا, your mic is totally unclear. We cannot hear. دكتور لوتون.
عمر كده احسن؟
كده كويس. كده مسموع. كده مسموع. دكتور لوتون. دكتور مايكل لوتون is here or not yet?
سمعكم مزيكا بدل الاغنيه، بدل الموسيقى اللي بتنقض دي. Reschedule.
have to reschedule.
Hello?
Can
Can you hear me?
I can hear you, yes.
Yes, we have a fellow in Canada by Lawton, and he's speaking to he calling now, and he's an emergency, and we will wait for 5 minutes to know if he will join us or not.
Okay, all right.
Okay.
That sounds fair.
دكتور محمد، دكتور أسامة بيسمعوني؟ دكتور أسامة، دكتور محمد.
سامعينك، بس ده كلام مش كويس. يعني هو صغير عشان يعمل ايمرجنسي. ده احنا كبار عواجيز بنخلي الصبيان يعملوا ايمرجنسي.
بيموتوا على الفلوس بقى. هنعوضك يا دكتور، هنعوضك. شوف الحاله بكام وهندفع لك النص.
لا ده راجل كبير، ده تشيرمان يعني. هو دكتور قرش، انت بتعمل ايمرجنسي بنفسك دلوقتي؟ معقوله؟ ما عندكش صبيان يعملوا لك؟
النهارده الجمعة سنة وانت طيب. ليلة عاشوراء.
خليهم يوطوا الموسيقى بتاعهم شويه، موسيقى عاليه وتنقح في الدماغ على طول. لو سمحتوا بس وطوا موسيقتهم.
لا، هات
الاغنيه احلى 1000 مره من الموسيقى.
انت هات الكاميرات، الموسيقى هتقف. لما تجيب صور الكاميرات الموسيقى بتقف.
ما انا جبت
دي مش يا ريتها موسيقى يا دكتور عمر، تقطع الدماغ.
ايوه مش كده. ايوه.
بقى ان احنا شفنا الحبايب من
يس.
بروفيسور كورشي، بروفيسور بيت، بروفيسور بروفيسور ناصر، صوته
سأورونا يا دكتور أسامة بيه. ايه اخبار اخر مغامراتك دكتور اسامه؟
Which one? I have a lot of things.
What's the most interesting event?
Within a couple of weeks, you will hear about it.
Hello,
declare it.
Good. How are you?
I'm
I
very
just
well.
communicated with Michael Lawton. He is saying just give me 15 more minutes, and he is coming. He is in operation, and unfortunately had complication, and so he asked if we can wait for 15 to 20 more minutes, and we are sorry about that. But he is confirming that he is joining us now after 15 minutes. Sorry, Mahmoud. Sorry for everybody. We just
محتاجين نكتب يا دكتور ناصر، محتاجين نكتب عشان الاتندين اللي موجودين، محتاجين نكتب.
احمد ممكن تفتح الشات ولا ما ينفعش؟
حد يفتح الشات بسرعه عشان نكتب يا جماعه، عشان في ناس ممكن ما يمشوا.
احمد مجدي
هو انا اسمح لي يعني اكتر من 5 دقائق هعتذر.
افتح الشات.
الشات مقفول.
ما ينفعش تفتحه دلوقتي؟
لا مش هينفع.
طب اكتب على الكيو اند ايه، اكتب على الكيو اند ايه.
انا مش عارف اكتب، انا باجي ادخل مش عارف اكتب.
على الكيو اند ايه يا دكتور؟
عايزين نكتب يا استاذ احمد، عايزين نكتب يا استاذ احمد. الو.
معلش I have to go. I have a family commitment. I may rejoin in 15 minutes. If he is there, that's fine. If not, I'm leaving. Thank you, everybody. It's good to see you all. Bye-bye.
Thank you, Professor Al-Fiqi. He confirms that he will come after 15 minutes. Please come again.
I will rejoin in 15 minutes.
Thank you very much. Okay. Goodbye.
اوكي. عايزين نكتب ضروري يا دكتور ناصر، عايزين نكتب ضروري. يا استاذ احمد مجدي عايزين نكتب.
مش هينفع نكتب يا دكتور عمر.
اكتب على الكيو اند ايه يا مجدي. كيو اند ايه.
وهو الوحيد اللي هيتكلم، مفيش حد تاني يتكلم.
الحل لازم نكتب يا جماعه، مش هينفع كده. عايز حل نكتب عشان الناس اللي مستنيه، في 70 واحد. لازم يكون في طريقه نكتب بيها.
يا دكتور عمر يا دكتور ناصر بلغ الناس موجودين معانا دلوقتي.
انا بكتب يا عمر اهو.
مفيش حد تاني يتكلم جاهز ولا هو بس الوحيد يا دكتور ناصر؟
معلش هو يعني هو الاونلي سبيكر، وهو معمول بالليل عشان هو كان مواعيده مشغوله، فما فيش. هو كان المفروض تامر حسن يقدم حاجه وما قدمش الحقيقه، هو مش جاهز.
انت لو قلت لي كنت قدمت لك حاجه عن الاوربت. عندنا شغل جامد على الاوربت يا دكتور ناصر، بس يلا
بجد؟
مش مشكله. عندنا.
طب معلش بقى، معلش.
جات اكتر رايحات ولا يهمك.
انا كتبت اهو، انا كتبت يا عمر.
كتبت فين؟ مفيش حاجه ظهرت خالص.
على الكيو اند ايه، انا كتبت على الكيو اند ايه.
لا مفيش حاجه ظهرت خالص.
لا مكتوبه.
خلاص ايه.
كتبت.
لا بس انت كده كتبت بترد على اللي كاتب ولا ايه؟
لا مش شايفه، الناس كلها شايفاها بتهيألي ولا ايه؟ اهو.
طب اكتب، معلش اكتبها كذا مره.
طب حاضر.
انا حاسس انت بتكتبها بترد على اللي كتب بس.
طب ثانيه.
عايزين نكتبها ان جنرال يعني.
طب حاضر.
هم كل الانتيت دي سامعيننا يا دكتور استاذ احمد. استاذ احمد مجدي. استاذ احمد مجدي.
هو احتياطي
استاذ احمد
اكتبها
مجدي
برضو يا دكتور عمر.
يا دكتور مع حضرتك.
اكتبها احتياطي على
استاذ احمد.
اتفضل يا دكتور مع حضرتك.
ايوه بقول لك كل الانتندي اللي هم ال70 دول سامعيننا حاليا داخلين معانا ولا لسه؟
داخلين معانا دلوقتي.
ها؟
معانا
طب okay. Dear attendee, we are sorry for this delay. The Dr. Lawton is in emergency and he will join us in only 15 minutes. Again, we are sorry for that. Just 15 minutes, Dr. Lawton, he will join us. Sorry for this problem.
دكتور عمر، ممكن تكتبها الاناونسمنت ده كسلايد وتعرضها؟ دكتور عمر؟
لا، عشان انا لا مش شغال، انا مش شغال من الكمبيوتر، لازم يكون حد عنده كمبيوتر.
طب
دي فكره والله.
ممكن تكتبها كسلايد؟
دي فكره. يا استاذ احمد. يا استاذ احمد، وانت متاخر علينا ليه في الرد يا استاذ احمد مجدي؟ اكتبها سلايد. تمام. سمعنا استاذ احمد؟ استاذ احمد، الو يا استاذ احمد. استاذ احمد، استاذ احمد.
He's muted himself.
استاذ احمد يا مجدي. استاذ احمد مجدي. Dr. Lawton is joining us now. Dr. Lawton? Dr. Lawton?
Ahmed, Omar.
Dr. Lawton, he joined us خلاص. He joined us. Dr. Lawton is here. دكتور ناصر.
أنا مش شايفه لغاية دلوقتي. I can't see him.
دكتور ناصر.
أيوة يا عمر.
لا he joined us. He joined us now.
He is already in the pan list. He is already in the pan list.
Yeah. Yes.
Okay.
راح فين؟ لا كان موجود يا دكتور ناصر دلوقتي. كان
عمر Dana will join first. She is his assistant, and then he will join. I think they are about to join now. This is what they told me.
I have seen his name and he's joining, then disappears.
They are trying to connect. Just wait for a few minutes.
Okay. طيب خلاص. Yes, he is now here. He's here, Dr. Nasser. Dr. Nasser.
Nasser is muted himself.
Dr. Nasser. Welcome, Dr. Lawton. Dr. Lawton. Professor Michael Lawton. Professor Lawton.
اسمه
Hello?
لوتون.
Hello?
Can you hear me?
لوتون لوتون يا
Yes.
عمر يا حماد
Ah.
بتنطق لوتون.
Okay. Lawton. Yes. Who is speaking?
Hi.
Yes. You are the assistant of Dr. Lawton or what?
He is not joined with your microphone.
Okay.
Dr. Lawton?
Hi, can you hear me? Hi.
Yes, we hear you.
Yes.
Dana.
Yes.
Dana, are you Dana? Hello? This is the assistant of Professor Michael Luton, Dana, or who is speaking?
شكلها جايه تعتذر لكم. شكلها جايه تعتذر.
Professor Osama, I already called them in the operation room, and he is going to join because there was a change in time. They misunderstood the time. Now they think that the webinar start 10 by Egypt time, and he was in obligation in operation. They already apologized about this misunderstanding. He confirms that he is going to join the webinar. Don't worry.
هي خرجت ليه؟ ناصر؟
They are trying. عمر هو عامل حساب ويبتدي هو حصل سوء تفاهم بالنسبه للتوقيت. هو فاكر الويبينار هيبتدي 10 بتوقيت مصر. They miscalculated the time and he is already in operation and he is finishing and he is going to join.
No problem, no problem, no problem, no problem. بس عايزين نكتب بس الكلام ده، وعايزين احمد مجدي يحط سلايد فيها دكتور لوتون يجوين دكتور لوتون. دكتور لوتون. Are you here? لوتون حاجة غريبة.
Saw his name there briefly.
Sorry?
I saw his name there briefly, and then
Yes,
disappeared again.
this occurs frequently, more than 5 times. He joined and
Omar was just speaking with Dana now. She tried his presentation. She entered for a few minutes. She was trying his presentation and she went out again. And just she says that few minutes he will come now.
Okay. Dr. Lawton, are you hearing me? Dr. Lawton? I can see his...
أحمد هو دخل أهو.
Yes,
وقت
Dr.
المسك لما
Lawton?
نشوفه.
Yes? Hello?
Hi, it's Dana. His assistant. Can you hear me?
No, sorry,
Hello?
your voice is totally
Hi.
interrupted. Your voice is interrupted. Please make sure the net connections. النت عندهم ضعيف معقول؟ Dr. Luton, are you hearing me? Dr. Luton? Hello?
Hi, it's
Yes,
Dana. Can you
we are
hear
seeing
me?
your camera. We're seeing you and we're hearing you.
Okay, great. He should be walking in the door any minute.
Yeah.
I will text him and let him know, but he should be on his way.
Okay, take your time. Okay.
مش قادرين تجيبوا لنا حاجه احلى من كده يا عم عمر يا حماد؟
خد احسن تكون تفهم كلامك، يعني ما هي شكلك انت السبب يا دكتور اسامه، انت السبب.
يعني البتاع مشوه وشها واسنانها مش ممكن كده، ده يعني
خايفين
لا
خايفين منك،
يعني
خايفين
بعد
منك.
الانتظار والغيبه دي كلها وفي الاخر مين اللي بيسكتني كل شويه؟ هو كلامي مش عاجبكم ولا ايه؟
ما اعرفش مين ده اللي هم خافوا منك يا دكتور اسامه.
هم بيفهموا عربي يعني.
Then did you try the presentation of Professor Michael Luton?
Unmute yourself, please. Unmute yourself.
Then please unmute yourself.
Unmute yourself, please.
All right, there we go.
Yes. Now.
Then did you try the presentation of Professor Michael?
I did not. I did not try his presentation.
Do you like to try it now?
Just tell me what to do. Yes.
Okay, just share screen.
Okay.
To check the presentation and the videos.
شايف يا أخي الأدب والتوتر، بنت متوترة لدرجة إنهم متأخرين شغالين بحرج يعني.
All right. I'm going to click share.
Yes.
You know what? I got to get rid of some
Yes,
stuff.
perfect.
Let me see. But you know what? I'm going to take it off there because I don't know where his presentation is.
Uh-huh.
Okay.
We just see that
if you just try any presentation just to make sure that the slideshow is working.
You know what? I feel uncomfortable doing that. I'll let him, just give him a couple more minutes.
Okay.
Okay.
Thank you. Okay.
عندك حق يا دكتور.
انت يا دكتور رضوان نوبي فوتوجينيك قوي، صوره جميله، ده احلى حاجه في الليله شفناها.
ده من ذوقك يا حبيبي والله، انت يعني عمنا في المسائل دي يا دكتور اسامه.
ربنا يخليك يا باشا، ربنا يخليك. واغلب الناس طفشت شكلها. شكلك كده هترسى عليك انت وناصر، لان انا بعد شويه هطفش برضه شكلي كده يعني.
انت شكلك عايز تطفش لسبب اخر يا دكتور اسامه. مش كده؟
بقى الهمه يعني. انت راجل انا عارف.
ايوه ما لقيتش حاجات مشجعه مش كده؟
انا قلت لك هقول لك المفاجاه بعد اسبوعين بعدين بقى.
طيب.
على فكره يا عمر
أيوة.
الحوار ده مسموع كله من كل الاتنديز.
طيب.
احنا مش في احنا we are not in a practice session now.
دكتور عمر عمر
Hello.
Hello. Hello.
Hi, how are you?
Lawton.
How are you,
Thank
Dr.
you.
Otto?
I'm
How
good.
are you?
I'm sorry
Yeah.
I'm late. I just finished operating, so
Don't worry, don't worry. We are waiting for you. All of us waiting for you. It's our great honor to join us.
well, thank you. I'm sorry that it turned out this way, that I'm late, but anyway, it's better late than never, as I've always said.
Yeah, we happily kept waiting for you, Dr. Lawton. No problem. We know you are exhausted now.
No,
Sorry
I'm
for
good.
that.
I'm good.
And while you are preparing your slides, may I ask you a question?
Yes, of course.
Just to melt the ice, Dr. Lawton.
Sorry,
Just
what was
to
that?
melt the ice. Have you been to Egypt before?
I have. I've been to Egypt once before.
When?
I was, let's see. I was in medical school, my first year of medical school.
Really?
Cairo.
Where and what part in Egypt?
Well, I was in Cairo.
You remember what school of medicine in Cairo you were?
No, this was when I was in medical school, but on vacation. So
Yeah.
it was a trip to Greece, and then from Greece to Cairo, and then home from there.
We are unfortunate because we were young, I think, at the time, and we haven't a chance to meet you.
Yeah. Well,
Have you?
Who knew back then that I'd even be a neurosurgeon?
Then it was Egypt or Cairo opened the luck for your future in neurosurgery.
Yeah.
Radwan, Michael is younger than you and than me.
I understand. He's 55. Yes. He's a nice gentleman. Have you been to Upper Egypt, Dr. Lawton?
No, I haven't. Only Cairo. That's the only place.
Oh, it is. We should invite you. We'll be delighted to have you with us in Egypt.
Yeah, well, it's one of those places that I've wanted to go to, and it just hasn't happened yet.
I hope it would happen soon after we get rid of the break of COVID-19. Looking forward to have you with us. Although the Red Sea area, no infection there. It is now open for tourism, and no problem about COVID-19 there.
Well, that's great news. Yeah, well, we had a big surge in infections in Arizona, and that was about a month and a half ago, and things have settled down nicely. So we're actually in pretty good shape ourselves right now.
Good. Great pleasure to have you with us.
Well, it's my pleasure. Would you like me to start?
Just a few minutes, please, Professor Michael, because we have President of CANS, Professor Mahmoud Qureshi was waiting. I just sent him a message now in order to come. I think Walid is here. Mahmoud already joined us. Mahmoud, can you start by your welcome speech?
Yes, it won't be much of a speech, but great to have you with us, Michael. This is Moody Qureshi from Nairobi, Kenya. And on behalf of the Continental Association of African Neurosurgical Societies, it's a pleasure for us to co-host you with the Egyptian Society. And I'm sure that a lot of members from our various continental societies in Africa have been looking forward to hearing your talk. So thank you, Nassus, for organizing it. And thank you really, Professor Lawton, Michael, if we will call you that, for joining us on this webinar. Looking forward to your talk.
Thank you. And let me say my welcome speech. Ladies and gentlemen, it gives me great pleasure to welcome all of you in webinar number 14 among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. As president of the Egyptian Society of Neurological Surgery, And on behalf of all Egyptian neurosurgeons, I would like to thank Professor Michael Luton for accepting our invitation to be our guest speaker in this webinar. I would like also to introduce two of our eminent Egyptian professors of neurosurgery, Professor Tariq Abdelbari. He is a chairman of the neurosurgical department at Zakazek University, and Professor Radwan Nubi. He is the former chairman of the Department of Neurosurgery at Asyut University. Thanks to all of you for accepting our invitation and for contributing to this activity. For all our audience, you can participate by chat questions through Q&A, and this will be monitored through the panel. For those who don't have Zoom application in their mobiles or laptops, there will be a live stream of this webinar through the YouTube channel of our organization and through the Neurosurgical TV of John Bennett. I am also glad to tell you that for all attendees, you can directly print certificates of attendance of this webinar through a special link, which will be sent to you after the webinar immediately. Now I will give the speech to Professor Walid Abbas. He is a professor of neurosurgery and the co-chairman of the Cerebral Vascular Unit at Cairo University. He will introduce Professor Michael Luton through a short biography.
Hello, can you hear me?
Yes, yes.
Yes, hi everyone. Can I share my screen? Yeah, can you see my screen?
Yes.
Oh, yes. Yes,
Yeah.
It's okay now.
Yeah. Hello everyone. Good morning, good afternoon, and good evening, according to your place in the world is. It is my honor and pleasure to introduce a worldwide famous eminent cerebrovascular neurosurgeon, Dr. Michael Luton. He had his medical degree from Johns Hopkins University School of Medicine, residency at BNI, cerebrovascular fellowship at BNI, and endovascular fellowship at the University of California, San Francisco. Dr. Luton is the president of the CEO of Barrow Neurological Institute and the chair of the Department of Neurosurgery. Barrow Neurological Institute is the top neurosurgical and neurology hospital ranked in the US. It is the largest neuroscience it's the largest neurosurgical hospital in the US. It had 11 operating theaters and 2 endovascular suites. They operate 5,000 brain and spine surgeries per year. It is ranked at the 2nd neurosurgery residence program in the US. Dr. Luton has treated more than 5,000 aneurysms, almost 1,000 AVMs, 1,000 cavernous malformation, 250 of them are in the brain stem. This is a picture of Dr. Spitzer, Dr. Luton, and Dr. Sontag. When they are in the new building, the new Neuroplex, which is an extension of the Barrow Neurological Institute. Dr. Luton has 3 books, the 7 AVM, 7 bypasses, and 7 aneurysms. I figured that Dr. Luton is fond of number 7. We are waiting for his next book about the brainstem cavernomas, and I wonder if its name will be 7 brainstem cavernomas. I don't know. He's a great teacher and mentor. Dr. Luton, this is a picture of him during the pandemic wearing the P1000, which they invented in the Barrow Neurological Institute. And during the pandemic, he launched the series of COVID Video 19, and now it's reached up to 65 episodes, which I recommend for every cerebrovascular surgeon. This is a picture of the conference room where Dr. Luton meets his residents, fellows, to discuss with them the pre-operative and the post-operative cases. This is another picture of Dr. Luton with his fellows and observerships from over the world. Personally, I contacted Dr. Luton many times to take his advice about cerebrovascular cases, and he's never late for showing his advice and experience. And one of the lessons I learned from him so much is when not to operate. I figure we all will be astonished by his fantastic presentation as usual, and at the end of this presentation, I all will be Lutonized. Thank you so much. Dr. Lawton, I think you can share your screen now, sir.
Okay. Okay, I am sharing, and let me now go into play mode. And with that, I think you should see my title slide. Can you see my title slide?
Yes.
Okay, great. Well, thank you for that warm introduction. Pleasure to be with you. It's such an interesting time that we're living in, where we can just flip our computers open and be connected and do these things. It really is fantastic. So what I wanted to talk about, and I know you're interested in hearing, is about aneurysm surgery. And I wanted to start with just some thoughts about mastering technique, because I know there's some young neurosurgeons out there that are interested in climbing that learning curve, and I just wanted to share with you some thoughts on that. I think that's why people attend these webinars, is to really try and climb that curve and improve technique. These are the tenets that I included in my aneurysm book that go into the management of brain aneurysms, and I'm just going to highlight a couple of these points. The first is the art of clipping. This slide is just meant to say that there's so many different ways to clip aneurysms. We have trays that have hundreds of clip configurations, and the shapes of these aneurysms are also unique, that it really is interesting and endlessly changing the different varieties that we see. I normally like to resort to the simplest possible clipping configuration with one clip if possible, but you can see here from this slide just how there's so many ways, and sometimes you need to intersect clips or stack clips. Sometimes you need to use fenestrated clips to maintain closing force at the distal portion of the neck, or to transmit a perforator like in this little illustration here. Or for some of these paraclinoid region aneurysms, we have these more complicated angled fenestrated clips. So there really are an endless amount of ways to fix aneurysms. And I think it's a real art form to learn what your clips can do and how you can best repair these defects. So these are 6 points that I think go into mastering aneurysm surgery. And I'll just go through each of these one by one. The first is the microscope. It's really an enormously, well, it's an incredible piece of equipment. It's the most important thing that we bring to the operating room. And it really is something that allows us to have superhuman vision. That magnification that we get and the ability to see things that we wouldn't otherwise be able to resolve is really just so remarkable. It takes us into this other world where we can just resolve all of this detail. The illumination is fantastic, and these stands, the microscope stands that have developed, allow us to do what I call being one with the microscope, which means with every movement that you make with your head or your body position, you can have the microscope follow you, even though this equipment weighs hundreds of pounds. And in order to do that, I use the mouthpiece. I sit down in this operating chair. I brace my elbows. I get as absolutely comfortable as I can so that my hands can be at their best. And I think that's really important to do whatever it takes to optimize your comfort and your stability. We don't really talk much about manual dexterity, shockingly enough, given that this is a surgical subspecialty, but dexterity is so important. And I think it means or requires that you really think about what each of your fingers is doing, whether it's to actuate the instrument or to stabilize the instrument or to brace your hand so that you get your entire fifth digit and your hypothenar eminence resting on something stable that allows your muscles to relax. It's really important to to do the things that make you comfortable and more dexterous as you move. It takes a tremendous amount of practice, and I've found that brain surgery is really one of those things where you have to really strive for perfectionism, and you can't ever seem to get to that end. It constantly pushes us to be better. Anatomy is so very important. It's a real privilege, as we all know, to operate in something that's so complex and so intricate. And the more you understand the anatomy, the better you become as a surgeon. So I think that knowledge that comes from spending time doing cadaver dissection, studying the relationships between arteries, veins, tracts, structures, landmarks, etc., really pays off in the OR. Now, these are some numbers just to put everything into context for my career. This is at 22 years. I'm actually just past 23 now and closing in on 5,000, but you can see the numbers here. Really been blessed to be able to focus a lot of what I do on the vascular work. And these are some of the numbers that have come from that. I've always believed that the pen is mightier than the scalpel. You can be the best technical surgeon in the world, but if you don't write and share your insights and publish things, then others don't benefit from that experience and that technical evolution. And so I've really believed in writing. I've encouraged my trainees to write. It's so helpful at so many levels. And I think, you know, one of the things is it just helps us to think about what we're doing and analyze what we've done and get better. The other important point about mastery is it really takes this desire to want to push boundaries. I saw that with Dr. Spetzler when I trained with him. We see it in athletes who are constantly trying to win more championships or achieve greater accolades statistically, like here with Michael Jordan on the basketball court. I think there has to be that willingness to push boundaries, to try things that are new and take risk. That's an important part of this process. So let's get started with some cases. This is a case just to show some of that art of clipping. And what you'll see here, this is a vertebral artery aneurysm. It's very broad-based. It's just distal to the origin of PCOM, so it's not technically a PCOM aneurysm. It's really more of a V4 segment aneurysm. This is the far lateral exposure that we're seeing here, just opening up the arachnoid of the cisterna magna. Here is the dentate ligament. And for all these aneurysms, it's really important to just, again, know your anatomy, carefully dissect the surgical corridors so that everything is really clearly visible. And as you do that, you can those rootlets at the 12th nerve, see the 11th nerve here, and really open up this vagoaccessory triangle where we begin to see the aneurysm here projecting medially. So this is the far lateral exposure with the condyle flattened here. You can see the vertebral artery. You can see the tonsils here. This is the pica loops coming together in the midline. And here's our aneurysm. So this is going to be an example of a crosswise tandem clip construct. So you can see that with the overlay of the nerves here, we don't have a ton of room to clip this aneurysm. So what I'm going to do is first soften it, and I do that with a temporary clip on the proximal V4 segment. This allows me to finish my dissection. And I'm going to clip this neck with two overlapping crosswise 45-degree angle clips. Here's the first of the two. The tips are going to go underneath the cranial nerves. They're going to go from distal to proximal. And you can see that the heel is going to sit right about at the halfway point of the neck. And the toe of the blade is right up against the dura of the clivus. And with this first clip, that takes care of about half of the aneurysm. And you can see that it's done in such a way that the nerves are in view and they're well protected. And now This next clip is going to go crosswise. So the two clips are in opposite directions. They're exactly the same clip, but you can see that they work through that same opening in the cranial nerves in here. And this heel is overlapping the heel of the first clip. The toe, you can see, is passing the neck here, and I'm working the blades underneath the cranial nerves. And so now we've got this aneurysm nicely obliterated. And you can see there's stasis inside the aneurysm. This is our endocyanine study showing filling of pica, filling of the vert, no filling of the aneurysm in this little space here. And this is just a yellow 560, another fluorescence study, just to look more carefully at the perforating arteries. And what we see here is good occlusion of the aneurysm. So this is just to get us started, just a simple clipping, not a very difficult one, but it shows you that far lateral exposure, that skull-based mentality, and the crosswise clip configuration. There's the overview. There's the post-operative imaging studies with a nice reconstruction there. Our next case is this one here. This is a small AVM with a large feeding artery aneurysm. There's the AVM here on the tentorial surface of the cerebellum. There's the aneurysm on the distal superior cerebellar artery. And by doing this case in the sitting position, I'm able to deal with both at the same time. So this is the supracerebellar approach, just opening up that supracerebellar space. This is a very nice AVM. It's small, grade 1, no real difficulties here. But moving on to the aneurysm, by thinking about how we can take care of all of the pathology in one, this position and this approach gives us the ability to first take out the AVM more superficially and then deepen our exposure and go to the quadrigeminal and ambient cisterns and deal with the aneurysm. So here's the AVM coming out. And now we can go to the quadrigeminal and ambient cisterns. Here's the tentorium over here. This is the quadrigeminal cistern here. We're moving forward into the ambient cistern. And you can begin to see the superior cerebellar artery there in that cistern. In the sitting position, the cisterns are nice and dry. You get gravity that retracts the cerebellum. And so it makes for this really beautiful exposure. This is the fourth nerve that parallels the course of the superior cerebellar artery. And here now you can see that aneurysm. It is projecting into the posterolateral midbrain. You can see the inflow here, the outflow here, the fourth nerve draped across the neck. And for this one, I'll use a temporary clip for softening. I'll use a slightly curved clip that parallels the course of the fourth nerve, and the temporary clip comes off. Now, for this one, as it turns out, I wasn't fully across the neck with that initial clipping. So as I'm looking through, I'm going to puncture the dome. Yeah, so I puncture the dome. You can see it's still refilling. So that means that the clip blades aren't fully across, and that's one of the problems when you are dealing with such a deep aneurysm. It's sometimes difficult to see that relationship of the tips. But just by advancing an extra millimeter, I now know that I'm across the neck of the aneurysm proximally, and now this aneurysm is completely occluded. So there you are. The aneurysm is opened up there. We're looking inside, and this is taken care of now. I just put a little padding to protect the trochlear nerve there. And you can see now the nice exposure that we get of this very unusual distal SCA aneurysm. Here's another interesting case. This was a intercommunicating artery aneurysm, very broad-based. This A2 here on the left side was densely adherent to the aneurysm fundus. And another surgeon explored this and just couldn't clip it. So what I'm going to do here is what I call the reverse picket fence. The picket fence is where the clips kind of go over the dome with the tips along the neck, and you use the tips of the clips to kind of reconstruct that neck. Here we're looking from underneath, so our orientation is flipped, and we're using the heels of these fenestrations here to reconstruct the neck. So here's that case. As we look in there, what we see is just to orient you, the optic nerve is here, the aneurysm is here. I'm going to take out a little gyrus rectus here to expose the aneurysm better. And this is the ipsilateral A2. The contralateral A2 is over here. And this was that really stuck plane that just would not open up. So I'm going to go on with a temporary clip. And now you get a nice overview of the aneurysm. This is the cleavage plane on the ipsilateral side between the A2 and the aneurysm. But as we look across to the opposite side, you see that this cleavage plane just doesn't open up. And rather than risk entering or damaging the aneurysm, I go with this reverse picket fence technique. So the first clip is like a fence post, and it goes right in the center of the aneurysm. And then this stack of clips then gets built out, moving from the inside to the outside. So here's another clip adjacent to that. And I'm just working my way. These are the recurrent arteriocubener and an atretic A1 on the opposite side. You can see the rings of the fenestration create this tunnel for the ACOM to live in and to flow through. So that transmits all of our perforators, transmits all of our communication across from left to right. And we just work our way from inside to the outside until we have this neck nicely reconstructed. So that's our last clip. There's our construct. And you can see how this reverse picket fence is a nice way to go. And when we look at the angiogram, you can see that reconstructed ACOM here. You can see good preservation of flow in the distal branches here, and an unusual case. I'm going to skip this case and move on to the basilar bifurcation. These are some of the tougher aneurysms because our working window is just so small and limited. But these are really great aneurysms, really challenging. These really are one of those benchmark cases. These are some of the dissection steps from following the PCOM back to from the carotid to the P1-2 junction, identifying the anatomy laterally, finding the third nerve, working our way back down to the P1 segment, finding the SCA, and then getting our proximal control here. For some of these basilar tip aneurysms, we need more. And this next case that I'm going to show you is an example of a transcavernous case where taking out a little bit of extra bone of the posterior clinoid, anterior clinoid, and back of the dorsum expands the working window so that you can deal with a challenging aneurysm. So here's the case. This is a 15-year-old boy from Europe. He was initially treated a year and a half before these imaging studies. He had a subarachnoid hemorrhage. He was coiled. The aneurysm recurred, so they stented him and added additional coils, and he recurred again. And you can see the aneurysm has continued to grow. It's really eaten away his midbrain. It's almost transected the cerebral peduncles here right down the middle. And he recovered from the subarachnoid hemorrhage. He was comatose for quite some time, recovered, and but was starting to deteriorate again with growth of this aneurysm. So what you're going to see here is now the transcavernous exposure. I edited out some of the clinoidectomy work to just show you how, after all of that work is done, we now have a great view of the anatomy through a carotid ocular motor window, which is really quite a bit larger than it normally would be. So this is the aneurysm here in the center. The basilar trunk is up here. You can see the tines of the stent in the basilar trunk. The SCA is here. The P1 is coming out here with the stent. Carotid artery is up in that upper part of the corner. So for this case, what I'm going to do is I'm going to use rapid ventricular pacing, and I'm going to soften the aneurysm. I'm going to completely, well, not completely, I'm going to partially trap the basilar quadrification. These are clips on the basilar trunk, the P1 segment. The next clips will go on the superior cerebellar artery, ipsilaterally here, duplicated SCA. Now we're going to go to the opposite side, and this is a clip on the contralateral SCA. And I don't have complete control. I don't have another clip on the opposite P1. But now I've got enough control to open up the aneurysm. So what I'm going to do is do a thrombectomy. This is a ultrasonic aspirator. I'm inside the lumen. I'm taking out all of the soft clot that is living around the coils. And you can see that by just doing that, I've softened the neck so that now I can do my clip reconstruction. So this is a giant aneurysm. It's going to take every bit of what my best clips can provide me with. So this is a fenestrated clip, and it's a 12-millimeter blade. And you can see that by having thrombectomized the aneurysm, I can get inside this plane on the far side. I can get inside the cleavage plane here on the near side. And I can get the neck to start to close. This next clip is going to advance from heel to tip, heel to toe. And this next clip gets all the way across the back of the aneurysm. And now these last clips will close the close the fenestration of the clips and also close this artery or this aneurysm incision that I made. So now the aneurysm is reclosed. We've reconstructed the neck of the quadrification, and you can see all of the branches coming out that look nicely preserved. So even with the presence of that stent, I was able to reconstruct this. You can see good flow in the basilar, good flow in the SCA. The P1 segment here fills out. You don't see it brightly because of the stent within it. And now with the CUSA, because he had such profound mass effect on his midbrain, I went back, took out every last bit of clot that I could. And now I'm just inspecting my clip blades, making sure I'm all the way across. Here's that large carotid ocular motor window. You can see here, it goes from the carotid out to the, let me back this up, from the carotid to the tentorial incisura, and because of the clinoidectomies, we've got a real nice wide open working space here in this expanded carotid ocular motor window. That's what the transcavernous exposure will do for this kind of an approach. Here's his before and after shot. This is the before, this is the after. You can see good preservation of the P1s bilaterally, good preservation of the SCAs bilaterally, and this aneurysm has now been dealt with, and he has done very well. He's back in Europe. He gets better every month, and you can see he's really been helped by this. So a couple of comments about giant aneurysms. Giant aneurysms, you can see the numbers here. They are only about 5% of my practice, which is about the right proportion. But what I wanted to emphasize was this number here. You can see that 44% of the giant aneurysms in this series were treated with bypass. And so I've come to look at a giant aneurysm as an aneurysm that has crossed a line. It's not the same as a smaller aneurysm and can't be treated in the same way as a smaller aneurysm. It really requires a completely different strategy, and that strategy really is bypass. Bypass is really a nice way to deal with these complex aneurysms that have really outgrown their normal configurations, where they have manageable necks or they have empty lumens. And the bypass approach has really been, I think, an important one. I'm going to show some ICA bypasses because when I wrote 7 bypasses, I didn't really pay much attention to the ICA bypass because I didn't see a lot of these aneurysms and didn't do a lot, but I subsequently went back and tried to apply this whole 7 bypasses framework to the ICA aneurysm. And you can see from this list and this picture just how you can really do all 7 of the different bypasses to the ICA just as you can for PICA, MCA, Basilar, or ACA. And I'm going to show you 2 examples of these. This is a lady who presented with this thrombotic ICA aneurysm. It was compressing her pons. She had weakness and sensory changes as a result of that. And when we just do a standard retrosigmoid craniotomy, as shown here, we get into the CP angle. This is the 5th nerve here. This is the 7th and 8th nerve bundle. This is our aneurysm up here. And now we're looking further inferiorly. We can see the rootlets of 12 and the 11th nerve. And just above that was PICA. And I was able to bring PICA to lie immediately adjacent and parallel to ICA. So what this bypass will be is an ICA-PICA bypass, where PICA becomes our donor, ICA becomes our recipient, and we're going to bring these 2 parallel vessels together for a PICA-ICA bypass. So we're seeing 2 arteriotomies, the first here in the ICA, the second one in the PICA. This first suture brings the 2 arteries together. This second knot here brings the other end of the arteriotomies together. This is an entrance stitch where the needle passes from the outside, where the knot is tied, to the inside. And then we can sew those 2 inner layers of arterial wall together. This is a running continuous stitch. It brings those that deep suture line together. We can tighten those sutures and tie it off here. And this is just a nice overview showing the deep anastomosis. Now, the second suture line is a lot easier. You can pull those walls up and over, and we can sew that in a continuous way. And now you can see the bypass taking shape. The clips come off. We now have PICA supplying ICA. And that's important because now with the bypass in place, we can turn our attention to what this lady really needed, which is this trapping and decompression of her pons. So now what we're looking at is the 6th nerve here, the ICA coming out of the aneurysm there. This is the 7th and 8th nerve bundle. And you can see this is our first clip that will distally occlude the aneurysm. As we look deeper, you can see the basilar trunk. Right in this dark space here, the basilar trunk comes into view. And there's going to be just enough room on the first segment of ICA right here to apply a clip and to trap that aneurysm proximally. So now the aneurysm is trapped, the bypass is taken over flow, this aneurysm is completely isolated, and we can go in, again, like on that last basilar apex case, we can go in with a CUSA, we can do a thrombectomy, and we can relieve the mass effect symptoms. So here's just a view showing that thrombectomy, the amount of decompression that we achieve. And the bypass is down here doing its job, reperfusing the ICA. I'm going to show you an indocyanine green study here in just a second, and you'll see that the bypass fills across and you get retrograde perfusion to all of those perforators all the way up to the ICA origin. So this is the ICA-PICA angiogram. You can see the nice connection there. And here she is, having made an excellent recovery. Here's another case. I'm showing you this one because it just is an example in my mind of how you can use some variant anatomy and your own creativity to come up with some unique bypasses. This is an aneurysm as shown in this drawing here that's distal to a dual origin of pica. It's a very rare variant. We see it very infrequently, but you can see an extradural branch and an intradural branch. They come together here, and then the aneurysm sits just beyond it. Well, when you have that, you can take one of those limbs, you can re-implant it to the artery itself, distal to the aneurysm, and then it provides you with a jump graft, its own jump graft that it can use to revascularize the distal pica. So here is an example of that. Here is that case. That's the angiogram. Here's the 3D animation showing this relationship. And what we'll do is we'll first trap the aneurysm. We'll then free the proximal branch. We'll swing that over to the distal pica, and we'll sew that end aside. And that allows us to then permanently trap this aneurysm while still maintaining the flow in pica. So here's the anatomy. What you see here is the vertebral artery in the distance, the two branches of pica coming together. There's their confluence. And this is our ruptured aneurysm. You can see here, it's covered in clot. I did make an attempt to clip this, but you're going to see it's really just a dissecting aneurysm that tears. And we've got intraoperative rupture here, easily controlled with a proximal clip. And here, as we inspect the aneurysm, it's really just a hole in pica. So here I transect the proximal branch of pica, the proximal origin, and I can swing it over to the distal pica itself. And now we can do this end-to-side reimplantation of that second origin of pica to itself distally. And this is really just like any STA-MCA bypass. You can see here the first suture line, here the second suture line, and tying it down. And now here's our little internal jump graft that bypasses the aneurysm, supplies pica distally, and now we can excise that dissecting aneurysm. So that was an example of what I call a fourth generation bypass. And what I mean by that is that there's the first generation, which is the ECIC bypasses that just use scalp arteries. The second generation is the interpositional bypass that again uses the external circulation as its donor. The third generation are all of these other intracranial bypasses, the reimplantations, the in situ bypasses, the reanastomosis, and the intracranial jump grafts. These are all what I would call third generation bypasses. But the fourth generation really comes about when you take the standard bypass, like for a reimplantation, but use a different kind of anastomosis. Instead of an end to side, you use maybe an end to end or side to side, or you use a technique like the intraluminal suture technique that I showed you for that Ica-Pica bypass to do the construction. And these create this fourth generation of bypass. And I think it really expands what we're able to do with our bypass creations. I'm going to show you an example. This is what I call a middle communicating artery. Oops. This is the animation. So it's a very complex MCA bifurcation aneurysm. It's actually a trifurcation. And so for this one with two outflow arteries, what I'll do is a double barrel STA-MCA bypass. You can see the arteries going in there. But now that the bypasses are in, and I trap the aneurysm, I have the two ends of the trunks that I can bring together and create this middle communicating artery. It functions like an anterior communicating artery or a posterior communicating artery by redistributing flow to the different trunks as needed. And I thought that was important in this case because, as you'll notice here, these trunks coming out of this aneurysm are enormous. And our STA donor vessels are not nearly as large. They're probably less than half of the caliber. So I'm going to speed this up, and just, you know, as we do these STA-MCA bypasses, you can see that the STA is quite small in caliber. The recipient artery is quite large in caliber, so there's a mismatch. And so by creating a communicating artery, we make sure that whatever flow needs to get to whatever trunk, it can happen through either of these two bypasses. It's not dependent on just the bypass itself. These are the completed double barrel bypasses will now trap our aneurysm. These are two clips on the outflow vessels. Our indocyanine green dye at this point shows you the flow in the bypasses. But now, by doing this middle communicating artery construction, we can allow those bypasses to really recirculate. This is now just doing the proximal occlusion with these 3 additional clips. And now here's creating the middle communicating artery. That first trunk is transected. That second trunk is transected. The 2 ends of the artery are going to be reimplanted to themselves. So this is an end-to-end reimplantation. So most reimplantations are end-to-side. This is end-to-end. Oops, sorry. Sorry about that. There we go. Now we're back on track. So this is where we were before. This is the 2 arteries coming together end to end. So you can see that I've sewn these together on the inside of the artery. This next suture line is on the outside of the artery. So basically on 2 counts, this is what I would call a 4th generation bypass, using that intraluminal technique and also using an end-to-end reimplantation technique. And now as the clips come off, you can see that those 2 trunks now can communicate with each other. You've got one STA here, another STA here, and a communication between the 2. And that allows these 2 bypasses to redistribute the flow as the demand dictates. So there's the post-operative angiogram. You can see good reconstruction of the candelabra vessels. Now here's another example of the middle communicating. This was a dolichoectatic middle cerebral aneurysm that I clipped with this picket fence. This is the traditional picket fence. And we got a good result at the time. You can see good reconstruction of that bifurcation. But when I brought her back for the routine follow-up at 5 years, you can see that that aneurysm has regrown. So what we're going to do next is this trapping and middle communicating artery creation. So this is going to be a high flow bypass from the cervical carotid artery. Then we're going to reimplant that trunk on the opposite trunk, and then we'll trap the aneurysm. And our middle communication is right here between the 2 trunks. So that allows one bypass here to distribute amongst the entire system. So here now is the view in the Sylvian fissure. This is 5 years after a prior operation. You can see all the scar tissue. You can see the 2 divisions, the 2 trunks, one here temporally, one here frontally. And I'm going to begin by doing a high flow bypass to the cervical carotid artery. So this is the external carotid artery in the neck. This is our radial artery graft. And this will be an end to side anastomosis. You can see a nice fish mouth. You can also see a nice aortic punch hole in the external carotid. And here's the final sutures in that reimplantation of the graft to the external. And now we tunneled the graft up to the Sylvian fissure, and we're back up at the end. Here's our radial artery graft, which we're going to implant onto the temporal trunk of the middle cerebral vessel. So here it is here as it comes out of the aneurysm. This is our arteriotomy in the recipient middle cerebral vessel. These are our anchoring sutures. And now we can run that suture line. Again, I like the running continuous technique. It's faster. It's not as much time wasted tying knots. But we've got that now implanted here on the temporal trunk. Now, what you'll see next is, well, this is the indocyanine green just confirming patency. But what we'll do next is we'll take this trunk off of the aneurysm. We can use this proximal end of that recipient artery as a new donor in and of itself. So this is trapping that artery, and we're going to free it from the aneurysm, and we're going to bring it over to here, which is that frontal trunk. So we're repurposing that recipient as now a new donor. So here's our first stitch. We're going to reimplant it here on one of the branches on that frontal trunk. This is the completion of the deep suture line. Again, this is that intraluminal technique, which makes it a type 4A or a fourth generation bypass. This is now the completed anastomosis. And so now we've completely revascularized that bifurcation. This is now going to be a distal clip occlusion of the aneurysm. Because of those lenticular strides that you just saw, I'm not able to completely trap this thing. But I can do a distal occlusion, and that takes care of it. So one more example of an MCOM. The previous ones were EC-IC examples. This now will be an IC-IC example. You can see this unusual anatomy of the aneurysm itself. And so for this one, what I'm going to do is I'm going to use the A1, this vessel here, as a donor. And it's going to be an intracranial donor that I can attach or connect my graft to here, and then reimplant the other end over here. So it's going to be a short intracranial jump graft. Once that's in place, I can then bring those two trunks together like I did for the first one and create that communication. This is an overview of the aneurysm anatomy. You can see the trunks here on the temporal side and on the frontal side. This is the A1 bypass. So I'm sewing it to the A1 segment, just medial to the carotid terminus. This now is the reimplanted graft. It jumps from A1 to M2. And now with that in place, we can clip the M2s. We can take each one of them off of the aneurysm. Here's the other trunk. You can see how fragile this tissue is here. But now we transect the frontal trunk off of the aneurysm. We can flip the aneurysm out of our way. And now we bring these two transected ends together. So looking here, you can see now the two M2s that come together on the deep side. See, there's a little bit of tension there, but this comes together nicely in the end. Here's our completed bypass. This is an M2 to M2 anastomosis here. And let me take you to the end here. This is our endocide in green, showing a good M2 to M2 connection here. The aneurysm is distally occluded, so there's a little stasis, stagnation of flow there, which ultimately thrombosis. And we've got good flow in our bypass. So here's the overview, A1 to M2, and then M2 to M2. There's our overview. You can see A1 is the donor and our reconstruction back here. Here's the postoperative angiogram study showing this nice reconstruction. You can see here this nice jump graft from A1 around to M2 and then M2 to M2 across. So let's see. I'll finish with one more case. Let me show you this one. I think the dolichoectatic basilar is one of our hardest aneurysms left to deal with. And, you know, we've tried many things. We've tried EC-IC bypasses. I've tried vertebral artery to SCA bypasses. I've tried the M2, P2 bypass. I'm going to show you this case. This is an example of that M2, P2 bypass for this lesion. It's a thrombotic aneurysm that this gentleman presented with compressive effects on his brainstem. You can see this anatomy here. The idea is to do an M2 to P2 bypass, trap the aneurysm, go inside, remove the thrombus, close the opening again, and by plicating that wall together again, remove that mass effect. So here now is just the Sylvian Fischer dissection. This is the arrival at the P2 segment at the deep side. This is the aneurysm here, the basilar trunk at the outflow from that dolichoectatic segment. You can see the little perforators. And so for this one, I'm going to first do the deep anastomosis to the P2 segment. So this is our P2 recipient here. This now is the anastomosis between the graft and the P2. Very deep hole. This is about as deep as you can get. But you can see the P2 gives us some nice healthy tissues to work with. This is the radial artery graft that comes in. This is a view through to the deep suture line. Now we're showing the more superficial suture line. And this slowly comes together. Here's tying the knots on the last suture line. And now we close off the graft and we bring the other end around and we jump to the M2 portion. So let me show you that. This is the M2 portion of the bypass. This is the intraluminal anastomosis, bringing those deep walls together. Here's the completed bypass. And now M2 can supply through this graft down to the P2. So with that in place, we've got the upper basilar trunk revascularized, and that gives us a tremendous amount of security to now attack the aneurysm. So now what we're looking at here is the exposure of the aneurysm itself. This is a transcochlear exposure. This is Troutman's triangle, posterior fossa dura. This is now entering the cerebellopontine angle. You can see the aneurysm here. This is the 7th and 8th nerve. Here, this is the proximal side now of the aneurysm. You can see both of the vertebral arteries come together and form the base of this aneurysm. You can see the 6th nerve there. And again, as in one of my earlier cases, I mentioned rapid ventricular pacing. I'm going to use that in this case as well. You can see that when we overdrive the heart, we can drive the heart rate up to the 120s. The blood pressure drops down to the 40s or so. And now this aneurysm still has some pulsation, but it's very soft. And we can aggressively mobilize the 6th nerve off of the front. We can now close off the distal basilar trunk as it leaves the aneurysm. We can close off the 2 vertebral arteries on the other side that feed into the aneurysm. This is the first one here. This is the ipsilateral V4. So now with these 3 clips, the aneurysm is isolated. We still have ICA feeding this thing, but we can enter the aneurysm. And what you'll see here again, I love this CUSA. It rapidly thrombectomizes the aneurysm. It removes that mass effect. And you can see we're converting this tumor with tremendous mass effect on the brainstem into a sac, empty sac. And here now, if you look very carefully at the bottom of your screen, you can see the origin of ICA here at the depths, backfilling into the lumen. We can fold this aneurysm together. We can reapply some clips that will plicate the aneurysm closed and keep it from growing to the point where it compresses the brainstem again. So once again, we are going to make one of these picket fences of clips. We reclose our opening. This is removal of the aneurysm clip on the distal basilar so that our bypass can fill retrograde. And now we've completed our operation. We've got our bypass in, we've got our aneurysm reconstructed. I've left the vertebral arteries closed because the bypass now fills retrograde down to the perforators. And all this was done through a combined orbitozygomatic transcochlear transpetrous exposure. So just to wrap this up, I think mastering aneurysm surgery is a very difficult thing. It's a lifelong pursuit, but I believe it depends on hands, head, and heart. You need to spend time developing your technical skills, the hands part of this. You need to, I think, be strategic in how we deal with these very complicated aneurysms, be creative, have good judgment about who you choose to operate. And finally, it's about heart. It's about, taking on tough cases, not always succeeding, bouncing back from your failures, trying to strive for perfection with every case, and hope that you get better as time goes by, which I think inevitably happens. This is a graph from my aneurysm practice, and you can see how it looks pretty good if you look at things this way. But if you look at the trends are not working in our favor. With endovascular innovation really pushing things, we've definitely seen this bending of the curve. And unfortunately, we're in a position now where we just have a diminishing amount of cases. There's less cases to teach residents. There are less cases to keep our skill level up. And so it does create challenges for us. But I think, we have to climb this learning curve where we go from curiosity, apply our discipline to achieving proficiency. We continue on that quest for excellence, and finally, evolving new techniques, new things that will make us even better. So with that, I'm going to stop. I think I've exceeded my time. And again, I really appreciate the opportunity to share with you these cases and some of these thoughts, and hope that was helpful for you. And stop sharing my screen here, and hopefully, yeah, there we go.
Thank you, Professor Lawton. I enjoyed every minute in your lecture, as well as your marvelous sense of humor. Thank you very much. I know that you are always kind, helpful, patient, supportive, and caring your profession and your students. And now we can
Thank you.
Open for the discussion if there is any question.
Can I have a couple of questions for Dr. Lawton?
Yes, yes, please.
Yeah, I want to ask, how often do you depend on ICG in your operation after clipping of the aneurysm, or sometimes do you use intraoperative angiography?
Yeah, the indocyanine green video angiography is so good that I use it in almost all of my aneurysm cases and actually all of my bypass cases. So it's become really a standard of care for me. And at the same time, I think it's supplanted or eliminated the need for intraoperative catheter angiography. I very rarely use intraoperative catheter angiography. I think it's cumbersome and doesn't give us sometimes the detail that we need. And so I've really gone to indocyanine green. I think it's really a remarkable tool that lets us see so many things and learn so much about our clipping, but it's not perfect. There are parts, there's some aneurysms that you just can't see well with indocyanine green, and there are limitations to it, but I think for the vast majority of cases, it really gives you the information that you need.
Okay, and about the case of the ACOM aneurysm, the one you use the reverse Picket Friends technique. So you used the orbitozygomatic approach. Wouldn't you have prefer the bifrontal approach so that you have both A2s if anything happened, or?
Yeah, I think in that case, it might have been a good way to deal with that. The bifrontal approach is nice because you come down on the dome, and you could have done that with the traditional picket fence. But you know, the problem with the bifrontal exposure is it's a very big craniotomy, and it sometimes doesn't give you the exposure or control of the A1s as they come in. So this patient was previously operated with a pterional, so I wanted to use the existing approach. But even still, I do almost all of my ACOMs from a standard pterional or orbitopterional approach.
Okay, and about the basilar bifurcation aneurysm. So when do you use the transcavernous approach, and when do you use the orbitozygomatic approach? And like, how much time does the basilar artery can tolerate the temporary occlusion?
So I use an orbitozygomatic all the time. Whenever I do a basilar, I like the additional exposure that the orbital bar removal gives you. And so that's just the standard. And the nice thing about that approach is that you can change your angle. You can go from a trans-Sylvian direction. You can go from a subtemporal direction if you need it. You can go from a more anterior supraorbital type direction if you need that. So the orbitozygomatic keeps all of the options available to you. So I like it for that reason. The transcavernous is something I just do when I think I need that extra space. I use that sparingly. I probably do that maybe 10 times in a year, but that's probably it. So it's just for those really rare birds that are particularly challenging. So I think all of us, you just have to judge with each case, do we have what we need with the OZ? And if not, will the transcavernous give us what we need? And if so, then I add that in. As far as the temporary occlusion time, every patient's different. Everyone has different collateral circulation. So there is no magic number for the time of tolerance for basilar occlusion. I think the answers come in your monitoring. As you monitor the case, and if you put a clip on the basilar trunk, you can have signal changes within minutes in some cases with poor collateral. You can have other patients who don't change their monitoring at all for 10, 20 minutes. Those are patients that have strong PCOMs or have other collaterals that allow them to tolerate it. So I think you just have to read your intraoperative monitoring, but I also think you have to really focus on surgeon speed, you know, save that temporary occlusion time for just the last few maneuvers at the very end.
So I want to, sorry for overloading you, but I want to ask about the cases of the giant MCA. Like in a case, you do like a double barrel STA to MCA, and in another case, you do like an high flow bypass from the external carotid to M2. So do you measure the flow like how do you decide? Do you measure the flow pre-operatively or intraoperatively? When to do like STA?
You can do it one of two ways. I think one way is to do quantitative Doppler flow measurements that will give you numbers of, telling you how much flow there is in the vessels. The other way to do it is just to do it anatomically. And by that, I mean, you look at anatomically what the caliber of the vessels are and you match it. You know, some of those cases I showed you that I created the middle com, the caliber mismatch between the donor and the recipient was great. So I felt like we needed more. You know, for a middle cerebral artery bifurcation, I don't think a simple STA-MCA bypass is enough for me to feel comfortable. Some would say that with flow measurements, you can pick out those that have enough STA flow to supply it. But I like to be on the side of providing too much flow rather than not enough flow. So that's why in some of those cases I showed you, I elected to go with the higher flow interposition graft.
Any more questions, Dr. Wadi?
I think we are enjoying the great talk of Professor Michael Lawton. Thank you very much for this great presentation. We have a lot of well-known neurosurgeons. We have Professor Hisham Basuni from Germany, Professor Enrique Oserio, who is the president of the World Congress of Neurosurgery in Colombia 2021. Professors Muhammad Al-Faqi. We have a lot of professors. They are all in the panelists now. Professor Magdi Al-Ilini, he is Egyptian neurosurgeon, and he is already well-known in the United States. And we have many questions, and we can do a discussion now. Let me first say the first question. It's Professor Muhammad Al-Faqi. Professor Muhammad Al-Faqi is honorary president of the Egyptian Society and the KENS. He is asking, you are a left-handed surgeon. Do you think it affected your ability to perform more anastomosis?
No, I don't think so. I think whether you're right-handed or left-handed doesn't affect your ability to perform the bypasses. I think that the left-handed surgeon is a disadvantaged minority. You know, we have to learn to live in a right-hander's world. And so I think it does things to our spatial relationships, and in our mind, we have to flip all of those illustrations that we typically read in textbooks that are drawn for right-handers. We have to flip everything. And so I think left-handers have a uniquely good spatial understanding of things, which I do think is helpful in surgery. But whether my left-handedness either helped or hindered my bypass performances, I don't think so. I think you know, when you're under the microscope, whether it's right hand or left hand, it's pretty much all the same. And it's really a matter of finding the best way to be comfortable and fluid and graceful in doing these cases.
We have another question from, I don't know from which country, Dr. Singh Bedi. Are you able to plan the entire surgical bypass strategy from pre-operative scans, or do you need to improvise your strategies intraoperatively?
Yeah, it's a good question. I think what I do is I look at my films, I study them very carefully, and I come up with a plan A, a plan B, and a plan whatever. When I get into surgery, there's a lot of improvisation at the time, because you never know how things will really look. You don't know how the tissues will react. And so you do have to be flexible. And so many of these cases that I showed you were improvised on the fly. And I think that's why part of handling these cases is, you know, preparation, being quick to judge the situation in surgery, being creative on the fly. I think improvisation is a really important skill.
Another question, Dr. Wael Albaz, how to plan bypass donor selection and how to manage in case it fails? Yeah,
so donor selection, I think it's just a matter of running down the list of options. So in my book, 7 Bypasses, you know, the idea is that with every particular problem, there's probably going to be 7 different options that you can come up with. If you just go down the list and ask yourself, how can I use an ECIC bypass? How can I use an ECIC high flow? How can I reimplant? How can I re-anastomose? I think if you get in the habit of looking at all 7 options for any particular challenge, you will have several that are good and several that may not be so good. But then, you know, you have already in your mind some ability to make those choices. So I think that's how I go about making the donor selection. I go in with options. I evaluate whether one is better than the other, whether one bypass would be easier than the next. And I just make a judgment where I think I can have the best outcome and the best success.
Okay, I have 3 more questions from the panel, and then we will open discussion from all the chairpersons. The next question, how much time for doing bypass during surgery? Time of occlusion for each vessel? And if you use any endovascular occlusion previous to the procedure? Any anesthesiology drugs used for bypass surgery?
Yeah. So, yeah, the time that it takes for a bypass is, it varies. Sometimes it's very quick, and sometimes it's very long. It depends on really how many sutures you place. I think for most of my STA, MCA bypasses, I place about 20 to 24 bites. And if you can get your speed up to 1 bite per minute, then it's about a 20 to 24 minute occlusion time. So that's typically what mine look like. Now, if you're sewing down at the P2, where it's a very deep hole and your range of motion or your visibility is not what it would be up at the cortical surface, then it can slow you down and you can get into times that can be in the 30s or longer. I think, you know, in the end, time matters. You have to be efficient and fast, but you also have to get the job done well. And I think it's more important to get a bypass that's put together well, that takes maybe a few extra minutes than it is to kind of race through a bypass and have it be sloppy or have it be occluded. One of the questions somewhere in there was, how do you deal with bypasses that are occluded? Well, I mean, there's so many ways that you troubleshoot these bypasses, whether it's opening up a few stitches to pull out thrombus or to take down one of the suture lines altogether or completely redoing it. There are many ways to troubleshoot the bypass. And I find that, you know, you have to be prepared to go through those. They're frustrating because you spend time and you think you've created a really beautiful bypass, and when it's not patent, it's always disappointing. But those are the moments where you really have to work hard to troubleshoot it and get it open.
And in the same question, he was also asking any anesthesiology, special drugs used during bypass surgery.
Right. So for anesthesia, I do all my bypasses with burst suppression, meaning we titrate anesthetic so that the EEG is down to about 10% of baseline. And so that provides some cerebral protection during the ischemia time. Barbiturates are the drug of choice, but propofol works fine. So that's the anesthetic. And the other question was, do I use endovascular occlusion during bypasses? And the answer to that is no. I think anytime you have an endovascular occlusion of an artery, it requires the use of heparin. You have catheters in the arteries, and I don't do it. I do all of my occlusions with temporary clips or AVM clips, the AVM micro clips.
Okay, another question, effect of decreased operative aneurysm load. What is the minimum required to take complex aneurysm?
Is he asking how many cases per year you have to do to be competent? Is that?
No, he didn't specify, just saying effect of decreased operative aneurysm load. What is the minimum required to take complex aneurysm?
Yeah, okay. Yeah, that's another tough question to answer because I don't know if there is a magic number. I would say that the more you do, the better you get. I don't know what that magic number is where you have to get to be competent. Magic number is to maintain your competency. But I would say, you know, in the heyday, when that I showed you that curve, the peak of that curve, I was doing about 280 aneurysms a year. Now it's fallen quite a bit. I think I'm at about 180 per year. So it's a dramatic drop, and I don't, that's plenty of aneurysms for me. If that gets cut in half again, if I'm doing under 100 a year, I think that, you know, I'll certainly miss it, but whether I can do a good job and take on these complex aneurysms, I know I can do that. I think, you know, we all have to get better with fewer cases in these days, in this day and age. And I think part of the way we do that is through lectures, through co-videos, through sharing our own videos that we make. These are all ways that we can also increase our competency as the case number declines.
Another question, Professor Michael. Role of flow directors in complex aneurysms.
Yeah, flow diverters are definitely changing the treatments of these complex aneurysms, and they're pretty impressive. I like what I see in some of these flow diversion cases. The periophthalmic and cavernous aneurysms really, that has become, flow diversion has become the treatment of choice for some of these complex aneurysms. I think for other regions like the flow diversions that you see being done for complex MCA aneurysms, I'm personally opposed to that. I think that some of these bypasses that I've been sharing with you are a much better, more predictable way to treat these, and those results are very well studied and well established. Flow diversion runs the risk of jailing perforators, losing branch vessels, and not effectively closing aneurysms fully. So I'm a little bit more skeptical, but you know, we have to see. We have to be open-minded and see how the published results start to look as people gain more experience.
Now I have the last question in the panel, and then we open discussion among all panelists. Does the amount of subarachnoid hemorrhage count in complexity?
I would say no. I think if you have a lot of blood and a simple aneurysm, it's still a simple aneurysm. I think if you have the same aneurysm, one ruptured, one unruptured, it's clearly more complex to do the ruptured case because you have to deal with the lack of a visualization, the swollen brain, the issues of vasospasm. But you know, in my mind, complexity has to do with the morphology of the aneurysm and not the fact that it's ruptured or not ruptured.
Okay, now we open discussion for everybody in the panelists.
May I have a question, Dr. Nasser?
Yes, Omar, please go ahead.
Yes. Thanks, Dr. Lawton, for this very interesting presentation and this great experience. My questions, what are your tips to maintain the bypass viable for a long time?
I put all of my patients on aspirin and I tell them to take it for life. So I think that's one thing that you can do is just to give a little platelet inhibition. But beyond that, nothing. I think the best secret to bypass patency long-term is to do a good bypass. And that goes into the construction. So that means, you know, when you do your arteriotomies, making a good fish mouth on the donor vessel, on the recipient, making a nice long arteriotomy that's 2.5 to 3 times the diameter. And if you make a large anastomotic area and good suture bites along the suture lines, I think that's as important as anything in long-term patency. The other thing is just good selection. If you've got a well-constructed bypass that's not indicated or the case selection is poor, then there may be no demand and it may not stay open. So that's a real important part of the calculus.
Okay, another questions?
May I ask a question here?
Yes, please, Professor Magdi Khalini, go ahead.
Dr. Lawton, this is a very spectacular presentation, as usual. My question to you as a master and innovator of surgery for complex aneurysms, how do you see the future of using the endoscopic technique in some of the basilar aneurysms, especially if you expect that these aneurysms would not need any bypass or other procedures to complement the exclusion of the aneurysm? And my second question is, how often do you use the adenosine during surgery when you clip the aneurysms?
Yeah. So if you're asking about endoscopic, endonasal approaches for basilar aneurysms, I don't think there's a big future for that, honestly. I think that the corridor is so long and so narrow that the best you can do is to just get a clip in with basically one shot at the thing. And if it fits, it fits. And if it doesn't fit, it doesn't allow you the ability to change angles, to shift the configuration of the application. It just doesn't give you the kind of freedoms that we need for that complex of an aneurysm. I've seen a couple endoscopic clippings of a basilar apex aneurysm, and they're actually pretty scary looking. So I don't think that's a real threat or a real promise in the future. With regards to adenosine, I think adenosine is a great drug. I use it a handful of times a year. I don't use it routinely. It's usually in the setting either of a rupture that I'm struggling to control, or in the setting of needing to collapse an aneurysm that is just really giant in size. But the problem that I've always had with adenosine is it's very short-lived. You get 30 seconds, maybe 60 seconds, and it's difficult to get a lot done in that time. The rapid ventricular pacing is much better because you can dial that on and off, almost like a switch, and you can keep it going if you need it. If you need more than 30 seconds, you can keep it going for, in some of those cases I showed you, we had rapid ventricular pacing going for 4 or 5 minutes or so.
Thank you.
I think we have two colleagues, they are raising their hands. Dr. Sylvia, I will open the mic for you to speak directly with Professor Michael. Sylvia, are you here? Hello, Sylvia. Can you unmute yourself and speak directly with Professor Michael Luton?
No, unmute yourself, Dr. Sylvia. Unmute yourself.
Sylvia, please, can we have your question? Okay.
She is muted. She is muted.
We have another question. Somebody raising hands too. And any other questions, please, because I can't see the name. He is registering through an iPhone. I can't see the name. Please speak if you would like to say any questions. Okay, let us go back to our open discussion. Professor Hisham Basyouni from Germany, do you have any comments or questions?
Can you hear me? I'm sorry, I'm bypassing two computers.
Okay. Professor Hisham Basyouni from Germany, do you have any comments or questions?
Thank you very much, Dr. Lawton, for this very nice presentation. Can you hear me?
Yes, I can hear you.
Because I'm bypassing two laptops now because of my own. The microphone is good, but I cannot hear very clearly. So I unmuted the other one. Thank you very much for this very nice and this very sophisticated presentation. I would have two problems in this treatment of complex aneurysms. The first one is about the ischemia time. Do you only depend on SEP, for example, or electrophysiologic monitoring? That's the first one. And the second one, if you're doing this complex bypasses, of course, the animation was amazing and also the planning was amazing. But have you experienced, because we are learning always from failures, have you experienced any of unexpected, for example, steal phenomenon. If you're, for example, bypassing the ICA to the pica. This would be interesting because, sorry, yeah, I start again. Because this would be interesting, or what failures have you experienced in these bypasses?
Yeah.
Yeah.
Well, so your first question is a good one. I really rely on SCP and EEG interoperatively to provide me with some feedback about tolerance of temporary occlusion. I have to say it's very unusual for patients not to tolerate the temporary occlusion. And I think part of that is just in selecting your recipient sites very carefully. Any segment of artery that has end arteries on it, end perforating arteries, is a very poor recipient segment. So for example, the M1 segment, I never use it. There are too many lenticular striates on there to trap for temporary occlusion. Same is true for the P1 segment. Those thalamoperforator arteries will get you into trouble if you were to use that. But if you go out to the M2, if you go out to the P2, there are very few, if any, perforators, and the tolerance there is really quite high. So the answer to your question is you've got to first select your recipient sites very carefully. Second, you have to monitor. The times that I do see drops or changes in SCPs or EEGs, I can typically reverse the changes with just hypertension. So sometimes I'll clip an artery, I'll get a change in the evoked potentials, and just by raising the blood pressure 20 to 30 points systolically, that's enough to reverse whatever change and get me through the temporary occlusion time. There are these collateral networks that just need a little bit of a push, and that's enough to get you through. Now, the other question is a good one. You know, if you're doing intracranial to intracranial bypass and you're using an intracranial donor, you know, the question arises, do you get steal or problems from using that intracranial vessel as the donor? The answer is really no, I haven't seen that. I use the A1, I use the M2, I use the P2, I use all kinds of different arteries, the pica, and you just don't see complications from steal. So I don't worry about that. I think if you can bring an intracranial artery together with another by whatever means, the flow in those cerebral vessels is so strong that it will adapt and respond to carry that extra load.
Thank you, Professor Walid Abbas. Do you have any comments or questions?
Yeah, I want to ask if there is an aneurysm involving the M1 segment with lenticulostriate, and we cannot clip, we have to do bypass. What's your strategy for doing?
Yeah, so M1 aneurysms are tough because of the lenticular striates. So the strategy generally is to bypass distally, and because it's the entire M trunk, MCA trunk, I usually like to do a higher flow bypass, like an interposition graft. When it comes to the bypass decision is pretty straightforward, but the aneurysm occlusion decision is a lot more difficult, because there, if there are lenticular striates that are involved in the aneurysm, then you can't trap the aneurysm. You just have to limit yourself to a proximal occlusion and let the bypass retrograde fill those perforators, those lenticular striates off of the aneurysm. So I think that's generally my strategy for those M1 segment aneurysms. I like to trap. If I can't trap, I'll do a proximal occlusion, but in both cases, bypass is usually indicated.
Thank you.
Anybody would like to say any comments or any questions to Professor Michael Luton?
I have a question, please.
Professor Mohammed Al-Fiqhi. Please go ahead.
Thank you very much, Professor Michael. What's your criteria for selecting which vessel to anastomose to which recipient? Do you do any preoperative flow studies in order to select them?
Yeah, so I like to do preoperative angiography because I can see the flow patterns and I can see the anatomy very clearly on the bypasses. I have not been a real fan of the ANOVA or the quantitative flow studies. You know, I think I generally make my decisions based on trying to replace whatever vessel I sacrifice with an artery that's anatomically equivalent in size. And that usually is how I go about doing it. And I think that very simple anatomic rule of thumb will get you through most of those tough decisions.
Thank you.
Thank you.
Can I have one more question, please? One last question.
Yes, of course. Walid, go ahead.
I found, sir, that you didn't use the occipital artery as a donor vessel. You did that like an ICA to PICA bypass, and you didn't use occipital artery at all. Is there a problem with the occipital artery, or just you prefer intracranial to intracranial bypass? It's easier for you.
Yeah, the occipital artery is tough. That case I showed you, I actually dissected the occipital artery and had it ready to go. But harvesting the occipital artery is time consuming. I think the patency rates with occipital artery are different than what we see with superficial temporal artery. So I generally like intracranial to intracranial bypasses in the posterior circulation. But that said, I've done plenty of occipital artery bypasses, and I think there's a time and a place for them. So I don't have anything against them. I just think that the harvest is long. We have developed that inside-out technique that we published a few years ago, where you can elevate the muscles as a block and then dissect the artery out from underneath, from the underside. That expedites the harvest. So, you know, I think there are ways to make that harvesting a little less painful, but it is a good bypass, and it's a very benign bypass too. You don't, like for the PICA, you don't involve a contralateral vessel. There's some good reasons to keep that one in our arsenal.
Okay, thank you.
I can see another question in the panel. What is your opinion in doing for selected cases awake aneurysm clipping surgery?
Never. I don't think I've ever done it. I don't think there's an indication for it. Aneurysm surgery means you don't have to ever get into the brain tissue. So there really is no reason why you would ever need to do an aneurysm case awake, in my opinion.
I think by this question, yes, another comment or question?
Yeah, it's Mohammed Fouad. Hi, Professor Nasser. How are you?
Let me introduce Professor Mohammed Fouad. He's the chairman of Cerebral Vascular Surgery Unit in the Department of Neurosurgery, Cairo University.
Hello, Professor Lawton. I want to congratulate you about this very elegant lecture, and I have a couple of questions for you. Can you hear me?
Yes, I can hear.
Okay, thank you. I just want to warn the junior neurosurgeons about the need for the vascular microneurosurgical techniques over those of endovascular usage for most of the aneurysms that we are dealing with today. On contrary to the general belief that endovascular is taking the priority over microsurgery. So I want to take you through a couple of aneurysms. I want to explore your opinion about the value of microvascular techniques over endovascular procedures. First, with the BCOM aneurysms, there have been many reports that the usage of endovascular techniques for become aneurysms that's more than 1 centimeter would be associated with a high risk of recurrence or recanalization, and the best option is to use microvascular clipping for become aneurysms. What's your opinion about that?
Yeah, I tend to agree. I think there are a couple of reasons. Recurrence rate is much superior on the microsurgical clipping side. The recovery of the third nerve palsies after rupture is much better on the microsurgical clipping side. The risks of open microsurgery for PCOM are quite low. So there are many really good reasons to continue to treat the PCOM aneurysm as a surgery first aneurysm or treatment of first choice for open surgery. So I would agree with that. I think other aneurysms that are like that include the middle cerebral artery. I think that's a really preferable aneurysm for open microsurgery. I think the SCA is another one, and pica. Those four aneurysms in particular, I think are really well treated microsurgically and probably have an advantage over endovascular because of durability over time and in most cases accessibility with open surgery.
And the anterior choroidal as well, do you agree?
Yeah, anterior choroidal as well. I kind of lump that together with PCOM.
And the ophthalmic as well?
Ophthalmic is a different story. I think the ophthalmic aneurysm is very well treated with flow diversion, and I think we're really losing those aneurysms. I also think that, the risk to vision in open microsurgery is not insignificant. I think it's getting harder for a lot of open surgeons to get really good at that dissection because they're not seeing these as much anymore. So I worry a little bit that we might lose that in the same way that we've lost the cavernous aneurysm. But that said, I've clipped ophthalmics, clinoidals, and dorsal wall aneurysms all in the last 2 weeks, and those are all clinoidectomy cases and open ring dissection cases.
Yeah, and how would you use the contralateral approach for medially oriented ophthalmic aneurysms, especially if they are small in size?
Yeah, I do it all the time, and particularly in the setting of an ipsilateral aneurysm. So for example, if you have a left PCOM and a right ophthalmic, you can flip both of them from the left side. I do think it's good. I think, though, to do a contralateral ophthalmic, if that's the only aneurysm that you're dealing with, is a little bit risky just because there is no proximal control. You have no proximal control. So I do think that it's hard to advocate for that as a primary treatment.
Okay, but you haven't used the hybrid rooms and the endovascular team to give you the proximal control through the endovascular job through the neck? No,
I don't. I haven't relied on that. We certainly have great endovascular capabilities here at Barrow. It's a phone call away, but I just, if I'm going to go for a contralateral ophthalmic, like you said earlier, they're usually small, they're very manageable, and I don't feel like I need to have that. I just, I'm cautious and confident that I can do it without.
Yeah. Okay. Have you used the suction decompression technique for managing some of the intracavernous aneurysms, or the?
Yeah. Probably not so much for the intracavernous as for the ophthalmic or the hypophyseals. I think it's a wonderful technique. It's never as easy as it looks. People show videos where aneurysms suck right down, and
absolutely,
getting the cannulas right and having some residual filling of the lesion. there are issues with it, but I think it's good in certain cases for sure.
Good. I came to believe that the large kind of thrombosed basilar tip aneurysms are relatively, and most of the time they are resistant to all kinds of endovascular treatment, and they tend to recur, and they have to be managed on the by the neurosurgeons. Would you agree with the same view?
Yeah, I do agree. That case that I showed of the 15-year-old boy from Europe is a great example. I think everybody looks for an easy way out. They view endovascular as lower risk, but you just get into trouble down the road, and then it's so much harder. I mean, that case would have been so much easier had I had the chance to treat that initially. So I agree completely with you. I think if you've got a thrombotic aneurysm, it's a crime to treat it with coiling.
Right. And I want to ask you about the blister kind of aneurysms. These are the ones that are definitely cannot be managed endovascularly, and they have to be dealt with by the neurosurgeons, and they do really represent a challenge for the neurosurgeons. What's your tips in managing blister aneurysms?
Yeah. Blisters are tough. I published my experience with my carotid blister aneurysms. The rupture rate is, I think it was 6 or 7 times higher than it is for the saccular aneurysms, and the morbidity is dramatically greater. So I think, I agree with you. It is a surgical disease, and I think we as the surgeons have to be, we have to have a very low threshold to resort to a bypass and trapping strategy. I still clip most of my blister aneurysms, but the ones that I've clipped and had intraoperative ruptures with have done generally poorly. And so I think when I get in there and size it up, if I don't like what I see, I resort to a bypass pretty quick.
Good. The other question is about this historically designed kind of shunt clips. I find them, they are very troublesome, and they are usually not.
I don't use them. I had a pair of shunt clips in San Francisco, and they sat on the shelf for 15 years, and finally my nurse came to me and said, you haven't used these in 15 years. Is there any reason why we need to keep these? And I think the answer is no. If you get into trouble, you can make a shunt clip by doing a wrap of the rupture site and a clipping of the wrap, almost like a sling. And that's I think, a better way anyways.
Right. I don't want to keep you so much, but my last question is about the ACOM aneurysm. Would you think about interhemispheric approach for any of the distally placed ACOM aneurysms, or you just use the usual Chiriomer?
I use the interhemispheric approach for the distal ACA aneurysm, but for most of the ACOMs, I still prefer the trans-Sylvian subfrontal approach. It's just what I've gotten used to through my training and my practice over my career. I think that we have published on what we call the squeeze play, where you can do both pterional plus a bifrontal and have both angles accessible. But I think by and large, the ACOMs I like from below.
Okay, thank you. Thank you very much.
Yes.
Thank you very much. Professor Adwan Nubi, any more comments?
Yes, please.
Okay.
Thank you again,
I'll have to go.
Maybe this is the last comment. This is the last comment.
Yeah, we can do one more.
We are sorry we kept you too long with us, and you already after a long day. Today here in Egypt, we are after midnight. We kept enjoying.
I'm sorry to keep you up so late.
Yeah. Being you are a co-founder for a teaching mission, to raise the standard of neurosurgical practice in developing countries in Mexico and Asia. And being you are truly kind, would you put Africa in consideration?
Yes, I'm very interested in spreading whatever teaching that I can do worldwide. And I promise you that I will do more in Africa. I actually have a meeting in an hour to talk about our Barrow Global Neurosurgery Program, which we're trying to develop. And hopefully that will include projects close to you.
Oh, thank you very much. And Professor Nasser El Ghandour is the president of the Neurosurgical Society in Egypt. I think, Professor Nasser, you have to arrange a visit for Professor
We already have a very important meeting next year in October, which is the third man's meeting. It's done with the British Society of Neurosurgery and the World Federation. I will send invitation to Professor Michael Luton. We will be honored if he will be able to contribute. It's going to be next year, 27 to 30 October 2021.
And he agreed now to consider Egypt and Africa as a part of the teaching mission team.
We already have a commitment now from Professor Michael Luton, and that's great, Radwan, really. We have a commitment.
No, I'd like to join the teaching mission team to be like Mexico and Asia.
Yes, okay.
Yeah. Thank you, Professor.
Thank you. Unfortunately, it is the time to close the webinar. It was really so much enjoyable. As president of the Egyptian Society of Neurological Surgeons, I would like to thank Professor Michael Luton for accepting my invitation and for contributing to this webinar. Thank you, Michael, for giving us such honor. It was one of the most successful webinars. And thank you for being so much kind and patient and for answering all our questions. I would like also to ask all professors of neurosurgery who contributed to this webinar, Professors Radwan Al-Nubi, Muhammad Al-Fiqi, Magdi Al-Qilini, Hisham Basyuni, Tariq Abdel Bari, Omar Yusuf. I would like to thank Professor Muhammad Suleiman. He is my student. He is a fellow in Canada. He was organizing this webinar and he was communicating with Dana and with Professor Michael Luton. Thanks to Utopia, thanks to all participants. For all attendees, you can print your own certificate through a special link, which will be sent to your email tomorrow. Thank you very much. Thanks to all of you. Goodbye.
Thanks, Dr. Nasser. Thanks, for all of you.